For patient history, a 53-year-old female is admitted to the hospital for the management of pulmonary embolism. She has a history of atrial fibrillation and has been on therapeutic doses of unfractionated heparin for the past 5 days. During her hospital stay, she develops new onset of thrombocytopenia and recurrent thrombotic events despite anticoagulation therapy. On examination, the patient has swelling and tenderness in her left lower limb with evidence of deep vein thrombosis. Additionally, she has ecchymosis and petechia on her extremities suggestive of a bleeding tendency.
Here are the possible clinical manifestations associated with our case presented. First, disseminated intravascular coagulation or DIC. It is a condition where abnormal blood clotting occurs throughout the body's blood vessels, leading to excessive clot formation and subsequent bleeding. Second is the antiphospholipid syndrome or APS. It is an autoimmune disorder in which the immune system mistakenly produces antibodies that attack certain proteins in the blood, specifically phospholipids. Third is the thrombotic thrombocytopenic purpura or TTP. This is a rare blood disorder characterized by the formation of small blood clots throughout the body's blood vessels, leading to low platelet count or thrombocytopenia and damage to multiple organs. TTP is caused by a deficiency or dysfunction of a specific enzyme called ADAM-TS13. Next is heparin-induced thrombocytopenia or HIT. It is an immune-mediated reaction that occurs in response to heparin, a commonly used blood thinning medication. Next for is hemophilia A or hemophilia B. First, let me have a brief discussion about hemophilia A. Hemophilia A is a genetic bleeding disorder caused by a deficiency or malfunctions of clotting factor 8, a protein essential for normal blood clotting. Next is hemophilia B. It is also known as Christmas disease. It is a genetic bleeding disorder caused by deficiency or dysfunction of clotting factor 9, a protein necessary for normal blood clotting. Lastly, deep vein thrombosis or DVT. It is a medical condition characterized by the formation of blood clot or thrombus within the deep veins of the body, typically located in our legs.
For our test ordered, we have coagulation profile. This is to evaluate and rule out disseminated intravascular coagulation. Multiple laboratory tests are typically considered. The specific test used may vary depending on clinical judgment and available resources. The commonly employed tests include activated partial thromboplastin time, prothrombin time, D-dimer, and fibrinogen assay. Second, we have lupus anticoagulant and anticardiolipin antibody testing to rule out APS. This test assess the presence of antiphospholipid antibodies associated with APS. Third, ADAM-TS13 activity and inhibitor assays. This is used to rule out TTP to measure the activity of ADAMS-TS13, a metalloprotease involved in regulating platelet function. And lastly, we have PF4 antibody testing to rule out heparin-induced thrombocytopenia.
For the test results, the test for APTT resulted in 31 seconds within the normal value of 20 to 45 seconds, being the interpretation normal. So for PT, 12 seconds within the normal range again of 10 to 12 seconds uh, with the interpretation of normal. That count, it wasn't in the range of 150 to 140 times 10 raised to 9 per liter. So it's decreased. Fibrinogen is within the normal value of 200 to 400 mgtl. Again, normal. But for D-dimer, it was less than zero point 0.5, so the interpretation is increased. So for the reason why the platelet count was decreased was because of the heparin-induced thrombocytopenia or HIT is a condition characterized by the decrease in platelet count caused by the use of heparin, a commonly used anticoagulant medication. HIT is associated with an immune-mediated reaction in response to heparin, leading to the formation of antibodies. So D-dimer is a blood marker that is frequently used to assess the presence of blood clot formation in the body. It is a breakdown product of fibrin, which is a protein involved in the formation of blood clots. When the blood clot forms and subsequently dissolves, fibrin is broken down, resulting in the release of D-dimer fragments into the bloodstream. So for the context of these two, so while they are interpreted as the reason for the decrease of platelet count, it is actually characterized as the activation of platelets and formation of blood clots. As platelets become activated as a response to heparin, it clots. So in a, eventually these clots may dissolve or become fragmented. So next is for the D dimer, why the D dimer is increased. So DVT again, as I explained, is refers to the formation of a blood clot. So with that, the vessels are inappropriately in the blood streams and dissolves again and become fragmented. Essentially, when these two are combined, it's a very, very hard case because these two are works in tandem so that the clotting problems stay within the patient. That's why platelet count is decreased and the dimer is
The result for lupus anticoagulant and anticardiolipin antibody was negative. This indicates that we can finally rule out the possibility for antiphospholipid syndrome. Both lupus anticoagulant and anticardiolipin antibodies are associated with increased blood clotting risks, particularly in the context of autoimmune disorders such as systemic lupus erythematosus, SLE, or antiphospholipid syndrome, APS. For the result of Adams TS13 activity and inhibitor assays was normal, and by that we can rule out the possibility for TTP or thrombotic thrombocytopenic purpura. Adam TS13 is an enzyme involved in the breakdown of a protein called von Willebrand factor, which helps regulate blood clotting. For the result of anti-PF4 antibody testing, it is positive and it is highly suggestive of the presence of heparin-induced thrombocytopenia.
The patient's clinical symptoms and laboratory findings are all consistent with the diagnosis of heparin-induced thrombocytopenia and deep vein thrombosis. A subsequent heparin treatment is a strong evidence for possible manifestation of HIT. Further confirmation was obtained through anti-PF4 antibody testing, and which is detected the presence of antibodies against heparin PF4 complexes. This usually does not happen in patients under heparin therapy. However, in rare cases, antibodies may form against the complexated platelet factor 4. On the other hand, the presence of swelling and tenderness from the patient is evident for deep vein thrombosis, especially in this case where it is evident in the left lower limb. Also, the abnormal result of D-dimer is highly confirmatory for the presence of thrombosis, especially in the case for DVT. So, possible treatment and management include immediate discontinuation of all heparin products due to the risk of increased thrombotic events associated with heparin-induced therapy. And close monitoring for potential complications such as bleeding or recurrent thrombotic events is also important. To sum things up, this clinical case presentation is a good example that ruling out diseases based on initial symptoms and clinical findings is no easy task. We have to perform tests that are integrated from different sections of the laboratory, like how we, in this case, used immunology and hematologic procedures to assay and rule out the disease. Of course, this is just a fictional example and does not represent anyone in the real world. Consultation with a healthcare professional such as a hematologist or critical intensivist is still recommended to determine the most appropriate tests and interpretations based on the specific clinical scenario and clinical symptoms provided.